Okay, welcome everybody. I'm going to be like a little bit more higher energy because I know this is that time, right? And it'll allow you to be lower energy if that's how you feel. Because I know some people are, kind of want to take it easy a little bit after a couple of days of conference. But I just wanted to say that, first of all, welcome. So this is WaSH and Healthcare Facilities. And it may actually be WaSH Healthcare Facilities, Electricity, Waste Management, Environmental Services, and possibly Climate Resilience. But I wanted to say that this follows a number of sessions and a lot of work where we collectively, I think, made a lot of progress. And I just wanted to say that, like right up front. I think, Ryan, you'll go through some of the history, but I feel like we're kind of at a natural inflection point following a few of these successes where we can think a little bit strategically about how we want to take this work at many different levels. And this is a genuine conversation because I'm not quite sure. There's so many changing things when I say inflection point. So we've talked a lot about changing funding and changing capacities to support, changing attitudes, many stakeholders, changing realities for governments, all this kind of big picture stuff, and then how does it kind of land with our group? And I think we've always, when I say our group, there's many different iterations of our group, from the UNGA discussions all the way through to our global strategic network, which is the high-level people. But this is, I kind of think this is our kind of behind the scenes, how do we kind of strategize and think about how we kind of move forward. So yes, I'm going to ask Anne to just walk us through a little bit of the agenda and how we're actually going to structure our time.
Great. Hi, everyone. I'm Anne from UNICEF. And so as Bruce was saying, this is kind of like a crowdsourced brainstorm where we're going to ask you for input into what's next for healthcare facilities. Because a lot of the success and momentum for healthcare facilities has come from the fact that so many of us are interested in this, and we're all working in the same direction, pushing this agenda forward. So we want to continue that momentum, ensure that where we go next is really reflective of what people are thinking and wanting for the sector. So the way we're going to do this is, first we're going to have a presentation really just on where we are right now and how we got here. So that's going to be a short presentation by Ryan Cronk. And then I'm going to ask a few presenters to make a 3-minute pitch. And so we've got a couple of themes. So one is on financing, we have one on monitoring and evidence generation, we have one on system strengthening, and oh boy, I think it's improvement, and one on facility improvement. So we're going to have the 3 pitches, and then we're going to invite reflections from you on, what's next in this particular area. So I won't talk much longer, but I would like to invite Ryan Cronk from UNC to give us a reflection on where we are and how we got here. Over to you, Ryan.
Thank you, Anne. So somehow Lindsay drafted me into doing this, and she's the one who has actually done all of these things, so I'm going to probably not capture all of it. But yeah, so I'm going to attempt to do a very high-level overview of where we've been over the past decade. And I would say maybe some of this work had its roots in this old green report that Jamie Bartram and colleagues did, I think in 2008, on essential environmental health standards in healthcare. But I think things really got kicked off when WHO and UNICEF launched the initial landscape report. UNC helped with that. We pieced together some data to kind of show that conditions were, of course, not great. And so that's what really started to kick things off. This obviously coincided with SDGs. And from there's been a number of strategic meetings that kind of jump around. Madrid, Geneva, London, Kathmandu, Zambia, Amman. Many of you were at these meetings, engaging academics, policymakers, government stakeholders, advancing the research agenda, practice-based summits. I probably missed a few meetings in here.
Oh, no.
SDG indicator working groups this corresponded with. There were some meetings in New York on schools and healthcare facilities. 2018 was a big milestone point where the UN Secretary General's speech, his global call to action on WaSH and healthcare facilities, really brought awareness to this issue at a much larger level among member states and UN agencies. There was then in 2019 the World Health Assembly resolution that really elevated this issue, with member states committing to work towards universal access to WaSH and healthcare facilities. There's been a lot of products launched too. WaSH Fit, I think 2018 was the first one, and it was revised in 2022. It's now implemented, it's probably more than 75 countries, I think. So WaSH Fit is sort of now kind of a universal thing. It was really exciting to see in one of the earlier sessions this week, almost everyone knew what WaSH Fit was in the room. So it's now a very mainline thing. The first global baseline report was in 2019 in launching of service ladders for WaSH in healthcare facilities, integration within sort of SDG monitoring. This is now what every other year, Rick, is WaSH institutions. There was the 8 practical steps that was launched, which we had sessions on this earlier in the week. This is one that kind of always flies under the radar, but pre-COVID, WHO listed the top 10 health issues of the decade, and WaSH in healthcare facilities was one of those 10. Of course, this got buried. This was like, by COVID. But I mean, it's now really, it is a tremendous issue, and integrates with a lot of other things. There was the 2023 UN resolution, which again recognized the need for, that's when we started to have this acronym that rolls off the tongue: water, sanitation, hygiene, waste, and electricity services. Obviously this is built on a tremendous amount of work from many of you all in the room. The Global Framework for Action, so this comprehensive framework to really guide and deliver results for universal access. This year, we already had the Global Progress Report on how to establish standards, conduct baselines. Lindsay presented on this just yesterday. And this was just something, Lindsay and I were talking about this the other day. This is like from a monitoring perspective. So the initial report was this sort of like sketchy, cobbled together bits of data from spreadsheets that I pulled together to now. Rick's got over 1 million data points from healthcare facilities, and that's incorrect, not 54 countries, it's way more than that. That was a typo on my part. So we've come a really long way when it comes to monitoring, and countries now monitoring the actual service ladders, not just sort of whichever hodgepodge indicators they have. This is some of that work that we will be releasing soon. We just finished up this systematic evidence map on WaSH in healthcare facilities, and there's been almost 4,000 studies published over the past decade. It's obviously spiking in COVID. A lot of these are hand hygiene related. We do have some work to go on this. I will just briefly say most of these are baseline assessments. Very few experimental interventions looking at impacts. I did hear there's a trial going on that did not get dosed, so we're excited to see some work coming out of Kenya and other places. So we're seeing a little bit of that, but there's really not a lot. So we're kind of stuck in this baseline condition. So we've come a long way, but now, like, part of our conversation today is we want to consider, just in light of all this uncertainty of foreign assistance funding, political change, this sort of community has sort of now very much gone from, working out of spreadsheets and, meetings and, slightly disorganized, trying to figure out what to do, to now a well-oiled machine and lots of structure in place, thanks to the leadership of WHO and UNICEF. So that's where we're going to turn it over to our experts to kind of look into the crystal ball and see what the next 5 to 10 years looks like in this space, around 4 topics that we picked on. I think first is policy and system strengthening, financing, facility improvements and sustainability, and then monitoring and evidence generation. So I think I will now turn it over to Ann, Bruce, and no more presentations.
Just stay here for a second.
Yeah.
So thanks so much, Ryan, because I think that was really hard to condense into a few slides, and you did it really well. But does anybody have any questions for Ryan before he disappears? Did he forget something major? No, I think you did a great job. Good job. Thanks. So I wanted to present I want to introduce our first speaker, who is Mary Oshinyo. So you may have seen Mary up on the big stage earlier. She's from the Ministry of Health in Ghana, and she is a very strong advocate for WaSH in healthcare facilities, and she's going to give us her pitch for what's next for policy and system strengthening. So come on up, Mary.
Hello everyone, good afternoon. Thank you, Anne. So what's next in system strengthening? I have taken notice of, let me see. 1, 2, 3, 4, 5, 6, but because I usually speak too much and take all the time, I'm just going to mention them and not explain any one of them in details in 3 minutes. So we have seen that funding is being withdrawn by USAID and other donors. So the way forward in system strengthening would be domestic resource mobilization. And I think the new key on the block, the latest word now is health sovereignty. And just last week in Durban, over 20,000 policy experts from the African member states gathered and they adopted the Durban promise. So health sovereignty is the topic now, making sure that countries, nationals themselves are mobilizing resources domestically. So that is the first one, domestic resource mobilization. The second one is domestic resource efficiency. So it's not always bringing more money, but the money we bring, how efficiently is it being used? That means that we need to strengthen accountability and governance mechanisms. The third one is domestic integration. So WaSH is a friend of many programs. It's not just WaSH. We don't do WaSH because we are doing WaSH. We are doing WaSH because of health, and I know this is political, but I'm not saying it for political reasons. I'm saying it for very technical reasons. We are doing WaSH for general well-being, and WaSH is also related to maternal and child health, antimicrobial resistance, infection prevention and control. So WaSH really is at the center of a lot of programs, and we need to make sure that we are becoming more integrated domestically within country when it comes to implementation. And this is very important for our health agencies. It has to start from WHO, UNICEF, World Bank, and all our donors. Because if it's not at these levels, when WHO is coming to country, they say, oh, WHO WaSH team is in Ghana, and then they are looking for the Ghana WaSH team. Yeah. WHO AMR team is coming to Ghana, they are looking for the AMR team. But what if we had a team from WHO, and there's AMR, there's WaSH, there's IPC, everybody is together. Then when you come in country, the government also tries to simulate the same governance mechanism, then we are getting integrated. Because you see, when it's time to report on glass for AMR, they say, oh, give us data on IPC. And they'll say, no, this funding didn't come from AMR, so we can't report it from AMR. That is how it plays out in country. When at the global level, it is not integrated. So we need to also attempt to integrate at global level, and that will be simulated at the country level as well. And then we also need to foster more domestic inequalities. How do I say? So, okay, so we need to pay attention to domestic inequalities in country. Because really what we want to do, or what we've been doing over the years, what we are trying to achieve, is translating all the global intentions into output for the general population. So at the point of implementation, we need to be prioritizing the less privileged, the less privileged, right? So we need to pay attention to the data and what it's telling us about inequities in country. So Ghana, we published a paper, we just used this data, and we try to look at the inequities. If you look at the hospitals at the southern parts of the country and the hospitals at the northern parts of the country, you'll see the economics of the regions playing out in WaSH as well. So in Accra and Kumasi, you see hospitals have good WaSH services. But when you now move to the northern parts of the country, where the economy is not as vibrant as in Accra and Kumasi, then you see the WaSH inequities also. So we need to pay attention. Then the final one is making sure that we are continuously positioning WaSH on the global health agenda. So now countries are talking about non-communicable diseases in LMICs. Usually cancers and NCDs used to be a problem that we thought was from America and Europe, not Africa. Africa, we thought that we had more infectious diseases, right? Now we are seeing more non-communicable diseases, and it is actually overriding the infectious diseases. We still have the pandemic response, which is led by the Africa CDC, but we are not paying too much attention to the NCDs and how we are positioning WaSH. So even if you came to the hospital with hypertension, I always give that example, because when we say NCDs are now rising, it doesn't mean we should do less WaSH. Because even if you came to the hospital with hypertension, and I still need to provide care as a nurse, I still need to wash my hands. So we need to explain to people and continuously maintain WaSH on the agenda, even if the epidemiology of diseases keep changing. And I'm happy that we talked a lot about epidemiology on the plenary for today. Okay, I hope I have done 3 minutes. Thank you.
That was great. Just ask you to sit here.
Sure.
You can be part of our panel. And I think that was really fantastic. Mary covered a lot of important points on the next steps with regard to policy, including the issue of domestic resource mobilization as one response to the changing global landscapes, that we really need to support countries in mobilizing resources for the health sector, better efficiency of spending of domestic resources, the integration of WaSH across health ministries and health agendas, both at national level and also in the global health agenda, and then also how we deal with inequities in access. So I thought those were really great points, but I did want to put it out to the audience now. If you have any questions for Mary or any thoughts on, is this the way forward for the policy agenda when we think about WaSH and health care facilities? So anyone?
Thanks, Mary. This is Nuhu Amin from ICDDRB Bangladesh. I think this is going through, transdisciplinary approach. You are trying to keep these people together to think. So my question is, from which stage we have to engage these people? It's not easy to engage, through the ministry, to the local government, then the municipal level, then the private sector. So which level you would like to engage them for the planning or design, or which level?
Okay, so from which level would I like to engage stakeholders for a multidisciplinary approach? I think that engaging at all levels is important. So, for example, when we have a policy dialogue, we would usually have someone from the national level, someone from the regional level, and then the district hospital, someone from the hospital level, and someone from the district health directorate. Someone from the clinical background, someone from the public health background, that is within health. And then when we usually have our national coordination, we have colleagues from the local government. They will help us with infrastructure. We have colleagues from Ghana Water Company. They do piping of water into our healthcare facilities. So I think for us, what has really worked is mapping out all the stakeholders. Because even in health alone, when you are talking about washing healthcare facilities, you need a different perspective to be in the conversation. So I think it's just mapping out everyone and making sure that every perspective is represented as much as possible. So I would say bringing all the levels together. There are some times that maybe for very political conversations, you would like to maybe just have high-level people in the room or have only operational colleagues in the room. But I think for the entire policy process, it's good to have every perspective represented as much as possible. Yeah.
Great. So in speaking to ensuring inclusion in the process of developing policies, and so I think that's really great, because it is a cross-disciplinary sector. I didn't hear much about institutional accountabilities, although I think it's hinting at that, right, in terms of roles and responsibilities for WaSH and healthcare facilities. I think we're talking broadly, not just on policy, but also on system strengthening, and Mary alluded to financing initiatives as well. Is there anything under this sort of broad topic that anyone would like to bring up? Yeah. Oh, thanks, Ryan.
Thanks very much. Mine is just a follow-up on the issue of engaging the stakeholders. You mentioned a very important point, that is mapping the stakeholders. Who is really responsible for mapping the stakeholders? And at what level of government does this happen? But also, how frequent do you engage the stakeholders? Because that's another important element. Bring all the stakeholders together, it's not an easy thing. So what's the frequency when you meet these stakeholders? And what's their commitment or participation in such kind of engagement? Because sometimes you really want to engage them, but they may not be there for you. So how do you deal with some of these things?
Okay, thank you. This just reminded me of one of the presentations I made at a senior managers meeting. So this is a meeting of all regional directors of health service, the Ministry of Health, the Ghana Health Service, and all the 30 agencies of the Ministry of Health. And when it was time for me to present, a few minutes later, a couple of colleagues came to me and said, "Oh, we heard that you're going to talk about WaSH. So we are anxious to hear about it." And after the presentation, two of the senior doctors came to me and they said, "Mary, so all this WaSH you've been talking about is actually just toilets and water." You know? So I think that you need to also map out multiple platforms. Because of funding, it's not always easy to bring everybody together at a particular time. So depending on the objective of the mapping out, for example, if it is a policy development, you might want to just, we didn't have too much funding to invest in policy development, so we would usually put together just a technical working group at making sure that all the levels are represented. And then when a draft document is available, we'll do a validation meeting. Usually it is the validation meeting that we bring most people together. That is because we usually want to reserve most of the funding for printing the actual document and disseminating, because there's no point really engaging a lot of stakeholders at the beginning, and when the document is actually ready, we don't have funding to disseminate to those who have to do the implementation. So I think that who you are mapping out and bringing to the table actually depends on the objective of what you want to achieve at every different time. And you also have to use different platforms. Whenever there's a policy meeting, you can actually talk to the conveners and tell them that the theme, you think that a presentation on WaSH would be very important for policymakers. Because sometimes when you say WaSH, some people don't get interested. They feel this is something they can send their technical officers to listen to. But the reason why we want high-level people to also listen to those presentations is because of political commitment. So if you also tailor-make the content to the audience and make sure it's as brief as possible, and you are actually playing emphasis on what you expect from them. So if it is creating an enabling environment for meetings and programs to be implemented, if it is telling the donors that WaSH is important so that they can allocate resources for it, those you have to be very specific to the high-level colleagues, what specific things you want them to support the program with. And for the mapping, anyone can do mapping. If you work at the national level, you can map out your stakeholders based on your objective. Even at hospital level, you need to map out the stakeholders, because you need to bring, the clinicians can be very stubborn. So they are key stakeholders, the clinicians, even the watchmen, the security men. If you just add one driver, one watchman, before then you add the clinicians, and then the people who do this and the WaSH work itself, the cleaning, and those who take care of the logistics for WaSH in the stores. So you see already, it's not just clinicians, but stores, drivers, security, all these people have something to do concerning WaSH. So anybody can do a stakeholder mapping. It doesn't matter the level that you're working, it just depends on the objective of the program that you want to implement. Yeah.
Super, thanks so much, Mary. And I'm going to go to Rick for, I think there are why don't we take two questions, one after the other, and then we'll come back to Mary.
Thanks, Dr. Mary. I wanted to follow up on this point about terminology. You said that sometimes when you talk about WaSH in healthcare facilities, people think, oh, we'll just send the technicians. do you think we should move away from this term? We were talking about how WaSH is part of a primary healthcare approach, but there's so much more than WaSH in that. I saw a presentation a couple days ago about environmental health services in healthcare facilities that included WaSH and a few other things, but I wonder if you could just reflect if you think the term WaSH helps or hurts us to advance the situation.
Mary, just before you answer, we'll just take the last question and then we'll come back to you.
Thank you. Mine will address what we discussed about, I think you said domestic integration and putting WaSH as a center in many of our programs. So my question is that now we are discussing what healthcare facilities, and recently we have also been talking about WaSH in schools, and tomorrow we are going to talk about WaSH in somewhere else, maybe in public spaces or somewhere else. And the question now would be, where do these problems start beating us? Because I think when we want to solve a problem, do we go downstream or upstream? And if you look at, and I'm glad that you are coming from Ghana and I come from Kenya, more or less similar countries. The problem is we have had many health facilities constructed, many schools constructed, and yet nobody sees water, sanitation, and hygiene as part of that infrastructure that you're doing. So we come later on to say, oh, we forgot to do WaSH. So, and now we are saying we have to integrate. There is the Ministry of Health that thinks about the health facility. There is the Ministry of Water that thinks about water. There is the Ministry of Works and Public Works or something that talk about the construction. Now, how do we put this house in order to ensure that when we talk about health facility, we think complete, and we move away from hardware, and also think that when we talk of WaSH in healthcare facilities, we also think about the software that goes with it. Thank you.
Okay. We have 3 more speakers because we can always come back to let's come back. Yeah. So should we? Let's have Mary respond to these and then.
Okay, so I'm going to keep it brief because I've already been warned that there's no time. So the first one about WaSH, whether there should be a different terminology. I think WaSH is okay because it's always been called WaSH and most people can relate to it. And it's a nice acronym, WaSH. But if along the line we find a better terminology that we feel stakeholders more relate to, we should consider. The only lesson from Ghana is because the program is called WaSH in healthcare facilities, what has happened is that we've made progress in bringing WaSH into healthcare facilities, but we haven't made enough progress in bringing WaSH into healthcare settings. So the mindset is always hospitals. So whenever we have to design a program, we are designing for just hospitals, not even the district health directorate. And it even takes us more effort to take WaSH to the health centers because the focus is in hospitals. So the non-hospitals, they are also places that we provide healthcare. So maybe we should be thinking of moving from WaSH in healthcare facilities to WaSH in healthcare settings. And I know that in some of the WHO meetings, it has come up before, but it's just that we've not taken it up. But in terms of implementation, it's really having impact on where the funding goes. So we need to probably discuss that again. Then the second question is about integration. So what has helped in Ghana? It hasn't completely been effective, but at least we've made an effort to make sure that our estate department has prototypes. So if you come to us and you want to help us to build a hospital, a district hospital, we have a prototype design, how we want our district hospital to be, how we want our regional hospital to be, how we want our health center to be, how we want our maternity homes to be. And they all have WaSH incorporated, how we want our chips to be. So you can't finish building a CHIPS or a hospital or a health center without WaSH facilities included. But before, what was happening is that we can have a health center and then we convert it into a hospital by just adding more departments and more wards. But now we have standard design. So design thinking is important. And bringing, again, it comes back to mapping stakeholders, the colleagues from the estate department. They have been very helpful in this support. And then coordination is very important. How do we keep everybody together? We have a coordination in Ghana. It's been running for the past 5 years. We have the Ministry of Local Government, the Ministry of Health, and then Ministry of Sanitation and Water Resources. So the trick is, now that government changed, there's no more Ministry of Sanitation. It has now been added to the Ministry of Local Government. But because of the initial coordination platform that we had, nothing has really changed. The only thing that has changed is paperwork and administration. But everything is still going on like it was, because we had already a coordination platform and everybody was working together. So you can also consider bringing a coordination platform. Yeah.
Wonderful. Thank you so much, Mary. So what I'm going to ask Mary to stay here because I know there's a lot more questions for you that are going to build up through the session. But I would like to introduce my next speaker, who is Claire Chase from the World Bank, and she's going to give a 3-minute pitch on financing, and then she will be available for questions. Thank you. Thank you, Anne. And a lot of excitement in the room, so I hope the financing doesn't put you to sleep. And I'm actually going to be sharing my slot with my colleague Linda Mabula, who's a senior health specialist in our health global practice, because we've been doing a lot of this work jointly, and she could not be here. So just to say that the World Bank hosted the last Global Strategic Network meeting of WaSH, Waste and Energy and Healthcare Facilities that Ryan spoke about. And the topic that, because we're always asked to talk about financing, and I felt like, but financing is such a black box. Like, what do we mean? It doesn't just show up at your door. But let's talk about investment readiness, because I think that's much more tangible, and it's actually a lot of the things that Ryan talked about in your presentation about things that this group and the broader, interested cohort is working on, is tackling those different pieces. So we're not starting from scratch, and I have a slide here. I don't know, it's probably too late to share it, but let me just walk you through what sort of how we conceptualized this investment readiness, so what is needed for financing to flow. And it's 5 components. The first on policy and strategy, which we think about that in terms of the costed national roadmaps, the plans for universal access to WaSH and healthcare facilities, and the clear priorities for elevating that in the national dialogue. Second, on the institutions, defining the roles and responsibilities for those different pieces. And also, importantly, the capacity for project implementation. So those institutions that are going to be responsible for delivery of the provision of the infrastructure and delivery of the service have the capacity to carry out that work. The management models, we had a session this morning talking through different management models for WaSH and healthcare facilities. Third is on regulation, so clarity on the service standards and the quality. The monitoring that's in place will be following up on those standards and having in place the accountability frameworks. The fourth component on financial sustainability, we've talked a lot this week about the long-term fund availability for operations and maintenance, being there, having a plan for cost recovery. It's not going to be an endless resourcing from the grant side of things. And then finally on results orientation, and I think there's a lot of very promising work that has been presented here around performance and outcome-based financing for impact. And that's, and I think these 5 drivers that we are talking about in the context of investment readiness, it doesn't matter if you're looking for financing from an MDB, from a donor, a philanthropist, or the government. I mean, they're all going to be wanting to see these elements in place. And I want to go back to something Dr. Mary said on the first day, which is
Why does Ghana receive so much financing? Because they're doing things, they're having impact, they're making progress. And so it's a way to crowd in those resources by having this success. So let me stop there, see if my colleague Linda can come in and compliment. Linda, are you there?
Yes, I'm here. Can you hear me?
Yes, we can hear you.
Okay, great. I'm struggling. I'm going to start my video in just a minute, but thank you, Claire. So I just wanted to add a few things, and I'll be very brief because I think Mary covered some of the things I wanted to say specifically on efficiencies and how to gain efficiencies. I think it's not just at the level of ministries of health, but also at the donor level, whether it's with bilaterals or MDBs. How do you create efficiencies? And I think one thing, initiative that we're working on internally at the bank is to coordinate between our water practice and our what we call health, nutrition, and population global practice. Um, and really to look at ways in which we can do mapping of where we're working, which healthcare facilities, which, for example, for cholera, in the case of cholera, PAMIs, and where we can actually jointly use our resources so that there's no duplication. And I think this exercise needs to happen across the board with multiple donors and not just internally within the bank, which is what we're doing. And so I think, for example, with regards to cholera, really making sure that we are leveraging existing resources for health emergencies, because we don't talk sometimes between sectors. And I think it's important to be able to see who's doing what where, not duplicate and create efficiency so that we have a single objective. So this, I think Dr. Mary talked a lot about this in the previous talk, but again, mapping, creating efficiencies, because as Bruce said, there's been an inflection point in terms of financing. So we do need to think very creatively how we're able to be more effective and do more with less. I'll stop there. Thank you.
Well, I mean, thank you, Linda. It's very nice to see you on the screen, and thanks, Claire. So this is a big topic right now, and actually it was an interesting transition because Mary, I was actually reading about the Accra reset.
Yes.
Before. I mean, this is your country leading this, and it's there's generated a lot of excitement, right? And this whole notion of having, as you sort of mentioned, Claire and Linda, and then you, Mary, like this, like having the right ingredients for investment to allow for sort of health sovereignty, right? National led, wherever the funding is ultimately coming from. You're going to have those ingredients in place. And actually having financing systems, I think in the words of your president, that actually work. So I think there's a whole mindset change here, and we're moving in definitely in a new direction. And against some of the doom and gloom, I think there's quite a bit of excitement because I think a lot of people feel like, well, this is actually time where we need change, right? And so, so I think that's kind of, I think, where we're at with this. I mean, there's a lot of, on our last report, we mentioned and highlighted, I think, in one of the earlier sessions, we talked a lot about these countries that have actually done a lot of the national actions that align with the things you're saying, Claire. I mean, having good accountability frameworks and results orientation, these kind of things, and yet there's still seems to be a lack of funding, and so there's the issue of aid, and then there's the issue of trying to unlock some of the private financing and trying to unlock, and I think Saroj always says he just challenges all the governments to put a little bit more public financing, and puts the figures up and says this is not something that is probably ideal to have some of this low investment in WaSH. So I think that's kind of my reflections on this. I just think everyone kind of has a role to play, whether it's at a more local level and trying to make this work, or trying to work with some of the big changes we're seeing in development. But does anyone have any comments about funding WaSH? I'm using that term now a little guardedly, in quotation marks, WaSH plus, in healthcare facilities or in health settings, Mary?
In health settings, I like that. Two thoughts. I mean, they're not necessarily direct questions, but like just things to think about. We talk a lot about these costed roadmaps and how critical they are, but I think equally important, we've talked a little bit less about the financing strategy that has to go along with that. Like, it's all fine and great if we calculate the cost, and obviously that's an important step. But I think without having this conversation about allocation and how this is actually going to move forward, we're at a bit of a standstill. And so some countries are doing the step of making the roadmap, but they're not actually putting the step. And I presented yesterday Ethiopia and Indonesia, which both had said like about 75% was supposed to come from various public, parts of government, and then 25% from donors. And I think that's really a critical step we need to be pushing countries towards, is actually that financing strategy that goes along with it. The other thing I wanted to say is about some of the things, Linda and the work you're doing, Claire the Bank, is around this demand for WaSH being in healthcare settings, being part of the ask to donors. When we first sat down with the bank, and it's probably like 8 or 9 years ago now, the response we got was like, but no one asks for WaSH in healthcare facilities, so we don't fund it, and we can't fund it if it's not asked for. And I think there's still an issue there. I don't know if we've fully gotten past that. Maybe Claire, you can speak to that. But I feel like we're in this in-between stage where we're recognizing the problem, and Ryan, you're showing baselines, we have the data, but is it really getting on the list of priorities of things that need to be addressed by donors?
So that was a question. And no, but
Like a hot mic.
It was, no, but I mean, just as you guys are maybe thinking about it, because this one really, I find, challenges me a little bit as well, because this notion of finding funding specifically for WaSH in healthcare facilities is a little bit of a narrow issue in the context of health systems. And so I think that's one of the challenges, is we're asking, for this narrow issue, and is it presentable like that? But anyway, take it as you want. I mean, I think there's just, it's over to you.
So, this is on. So I think that the costed roadmaps are incredibly valuable. But I would agree. I don't know that we need financing strategies for WaSH in healthcare facilities. I think that this costed roadmap, and I would say the same, and we just talked about this in the last session, the national cholera plans, those need to be inputs into national country strategies for achieving SDGs. And I think that's the direction certainly that the bank is going in supporting, which will be, I think, the what they're calling health compacts will be announced, I think, in December of this year for a number of countries. So these are basically priorities, national government priorities in the health sector. They're doing the same for the energy sector, that have an associated financing strategy and financing roadmap. So what part of that is coming from domestic resources, what part of that is coming from MDBs, from the private sector, including philanthropy. So I think that's where we're having all this groundwork done will be a critical input into these broader strategies, which I think it's, the whole sort of momentum towards this country-led approaches that I think you spoke about, it has to come from the government. And so they will define the priorities, but at the end of the day, I think there's still recognition that the SDGs are the right approach, and that's the right ultimate goal. So I don't think we need to worry about this not being a priority, because it is well recognized as a priority, but I do think that we will make more progress when it is fully integrated, when we don't have to keep adding on these other things like, yes, waste, and yes, energy, and all of these other things, which fundamentally, can we just go back to calling it a healthcare facility? Because that's what Dr. Maria always said, right? You can't call it a healthcare facility if it doesn't have WaSH. So, yeah, that's my optimistic view.
Can I add to that?
Oh, yes, please, Linda, go ahead.
So I do think that when you look at the way World Bank funding is prioritized in terms of interventions, the prioritization should come from the government, because it's funding that goes directly to governments. And often, when working in various countries, sometimes WaSH at healthcare facilities isn't prioritized necessarily. It can be in the context of either a maternal child health project or health emergencies project. It doesn't really matter, but I think those priorities need to come from the government, and these health compacts, I think, are an opportunity to leverage existing funding and projects to include this as part of a whole, and for us, for both sectors, health and WaSH, to really be more integrated. And I agree with what you said, Claire. It should just be called a healthcare facility, and without water, energy, it isn't. And maybe that should be. I think there needs to be more sensitization, not necessarily. I think governments like Ghana are doing an incredible job, but I think other governments need to kind of understand that they can ask this to be a priority when it isn't. Thank you.
I think that's very interesting. I'm going to take a comment from you, but just to say the health compact. I mean, I'm kind of excited about it, but it's also a little bit, there's the demystification. I'd love to kind of see how these work in progress, in practice. That's the word I was looking for. But please, sir.
Yeah, thank you, Richard Mugambe from Uganda Makerere University. I have a question around institutionalization of WaSH in healthcare facilities, and there are theories around social policy that indicate that issues that what we see on the policy agenda are issues that usually capture the attention of stakeholders, something called the issue attention cycle. And in reference to that, during the COVID pandemic, we saw that there was a lot of attention because of this issue of COVID. A lot of attention was given to COVID. And we saw that even from the presentation that Ryan gave, that a lot of publications came up during the time of COVID. Is there a possibility that, and when you look at actions in countries, indeed many governments came up with local initiatives to improve WaSH in terms of funding, but the actual practice of, for example, hand hygiene among healthcare workers also increased during the COVID-19 pandemic. But thereafter, we saw the trends going down. And in line with that, what are the lessons that we learned from COVID-19 that can help us to address issues of institutionalization of WaSH, and what are those lessons that can help us to address issues of WaSH in healthcare facility funding now? Thank you.
I think that wasn't.
Linda would be great.
Oh, I don't know if you heard that, Linda. Claire is volunteering you. But yeah, and maybe Linda, just please come in if you want. But as you consider coming in, let me just say, I think that's the heart of the matter here. And I'd be curious to understand. Rick's the data guy in the back. But just to what extent, some of these improvements that we're seeing, are sustainable over time, and to what extent can they be institutionalized? And, because this is not a behavior change alone issue. This is infrastructure. This is, training. This is policy. This is funding. This is the whole bit. You would like to think that there's some, kind of stability to some of these improvements over time. But I don't know, Linda, did you catch that question?
I did. So I think we should look at COVID-19, but other health emergencies like Ebola, virus disease outbreaks, as an opportunity to really strengthen the system. I think, during these large outbreaks, or during, a pandemic, we see needs with regards to water, with regards to, energy, with regards to oxygen. But I think we need to think about sustainability during the emergency, so that at the end of the emergency, we're thinking about resilience and sustainability, because I think without being able to access water, you're not able to respond to the next Ebola or Ebola outbreak or COVID pandemic. So we need to put that into our preparedness interventions, to include WaSH as a preparedness intervention. And I think this is something that DRC is doing. In one of the provinces that had the highest number of Ebola outbreaks, Equateur, the largest hospital, reference hospital, did not have access to clean water. And we were able to do that through World Bank funding, ensure access to water. And a month later, there was another Ebola outbreak and they had access to water and they were able to respond more effectively. But I do think we need to change our paradigm as donors, as governments, to make sure that WaSH is included as part of preparedness and resilience, and not just during an emergency. Thank you.
Thanks, Linda. And that was certainly a point you were making quite strongly, Claire, I think on the panel earlier. It's like we got to think about these things even before, people get panicked. And that's a challenge.
Just to add, I do think that, just from my experience, COVID was incredibly useful for this agenda because I think we started work, somebody mentioned, right, 2018, I think was the call to action. So we were working on this before, but that was like, kind of the rubber hit the road and we started to have a lot of demand for these services in healthcare facilities, certainly in the WaSH sector. All of our investments now, especially if they're in rural settings, include the institutional WaSH as part of the broader program. So I think I have seen the sustainability in terms of the demand for these activities. Now, whether those services are being maintained, that's something that we continue to work on as one of the main challenges. But
fantastic. I don't know, Mary, if you have anything you wanted to add? Yeah.
Yes, I wanted to say that when it comes to institutionalization with the COVID experience, one of the lessons that I learned is that WaSH happens in systems. So without systems, you can't really have WaSH. And you gave the example of hand hygiene, for example. When there was COVID, we provided Veronica buckets. There was water available. We provided soap. We provided guidelines that were laminated and put on the walls to remind healthcare workers of the process of hand hygiene. We provided all the so we provided everything that they needed to be able to wash their hands. And then we were also supervising, and there was monitoring and evaluation. So that's a system. It is a system that establishes WaSH. Now, when COVID is gone and all the funding is gone, we are no longer checking whether there's water in the Veronica bucket all the time. We are not checking whether there's always soap. So people, even if you go to teach them how to wash their hands, they can't wash their hands without water and soap. So when COVID came and we said, wear face mask, we didn't ask ourselves first whether people can eat in the first place before they buy the face mask to wear. So it's not like they don't want to wear the face mask, but they can't afford it. So WaSH happens in a system. If that is behavior change, it's a systems approach. You can say a lot about, behavior change, but without a system to make people change their behavior, they might want to change behavior, but they don't have the enabling system to change behavior. So first, WaSH happens in a system. We need to sustain that system, institutionalize the system to make sure that WaSH is also institutionalized. The second one is that WaSH should move from projects to programs. And we say it all the time, but in practice we don't. So for example, why in healthcare facilities we anchor WaSH in quality of care? And that is one thing that really helped. So WaSH is not, we don't talk WaSH alone, but we are talking WaSH patient safety. We are talking WaSH quality of care. So quality of care is like something that we talk about almost every day. And we try to frame WaSH as the foundation to quality of care. So programming is very good for institutionalization. And then the third one is monitoring and evaluation. In our country, we say that people only do what you are measuring. If you are not measuring, they shift attention to what you're measuring because they want to be seen as performing. So we should always continue the monitoring and evaluation. That incentivize people to keep doing the job and making sure we are bridging the gaps on all the key indicators that we agree to work with. Okay, thank you.
Okay, well, thanks so much, Claire, Linda, and Mary for continuing to be on the panel. I think Anne had a little strategy just to keep people on the panel, and so I can't let you back. You're going to have to stay there. But and then we're going to turn it to a new topic. But I just want to say we're talking about next steps, and this is clearly like a next step. Like this is, I think, one of the strategic pieces we're going to have to look at all the way to 2030. And the point about investment readiness, this notion potentially of health compacts and this idea of trying to how do we position this really important issue into a wider, kind of need, kind of express need by the country that covers, the health system's requirements that they need. So we'll pursue that, and I was going to say, Lindsay, I'm not sure if you're up next. You seem to be doing many things right now, but I think you're going to help us, to provoke us in terms of what's next in facility improvements and sustainability. Do I need to write notes now?
No, Darcy's on
Okay,
it. Darcy's
perfect.
on it. Don't worry. We change roles. I'm going to keep this brief because if there's anything you all have done, I am sure you all have been involved in facility improvements and you all have your own thoughts. Please don't ask me questions. This is about you guys sharing ideas. So I have three key things when I look at what's next in my crystal ball. One of which is around WaSH Fit. You saw the number of countries. It's been used very widely. It's great that it's got the adoption it has. It's now about institutionalization. And I think, Mary, you were just saying this about quality improvement. Like, it's got to be mainstreamed into these quality improvement efforts. I think yesterday we heard presentations like funding is always an issue. If it's a project, WaSH Fit's adopted, they like it, the money disappears from the donor, and then it's not being utilized. So I think we need to put a lot of effort into how do we actually mainstream it into what the facility is doing, and then how does that link to what the government expects of the healthcare facilities, and that might link to what we will hear next on monitoring. The second thing, and this should surprise no one, climate resilient can't just be an add-on. When we're talking about facility improvements, we have to consider climate resilience as part of the basic expectation of improving a healthcare facility. And then the third thing is on sustainability levers. So thank you for the presentation this morning from the UNC and World Bank teams talking about management models, but how do we better manage WaSH in the healthcare facilities? It's clearly something that's fallen between the cracks. We've been saying this for years, but then we haven't really come up with better solutions for it to not fall between the cracks. WaSH Fit is sort of a tool we've approached with it, but what are those models to ensure that the operations and maintenance happens every day? And so I think more research, and I mean that in like the most a practical implementation sense, what are those lessons learned that we can use? And I think the work that you all started about what are those, Darcy, you were sharing this morning, like what are all the things that make up a management model? We need to do a lot more and understand that in different contexts, faith-based facilities versus private, public, et cetera. So I'm going to stop there because I think you all have other ideas on what you might think we need to do on facility improvements.
All right, thanks so much, Lindsay, and great, okay, still on our panel, yes. So that's great, and I think we all know WaSH Fit, and we know how it works, but it is such a catalytic tool, and I think increasingly we're seeing, all these different strands of action that are emerging on climate resilience, on safe sanitation, on sustainability that are coming from its use. So like really a challenge in terms of how do we mainstream this into government systems and use it to its maximum potential. So I thought that was a great framing. I wanted to put it out there for all of you for questions, for Lindsay, or any of our illustrious panel, really, or just comments you want to have on this topic.
Thanks very much. Awesome comments. Adam Diller from PATH. I want to build on something you said, Lindsay, and it sort of goes to your point, Dr. Senior, about the efficiency of resources. And we'd love to see us push WaSH Fit data at the subnational level even further, to have greater granularity at the district and the facility level, but simplifying the process to roll up that data. So if you're a district administrator and looking at what are the costs that you want to have as a quality improvement plan over the next 5 years for your facilities, what does that look like in reality? And using kind of real estimates, and then be able to layer on things like, what does it look like with climate data? What does it look like with outbreak data? Having kind of scenario planning, but getting to that more granular subnational level data sets. I would love to be able to see that for planning purposes, and then simplifying that process using AI or whatever digital tools that we have, but to make that process for a district administrator to be able to see, here are the 10 things, here's the priority list based on the results and risks that we have in our district. Thanks.
Great. Well, maybe we could take one more question and then I'll come back to the panel.
Thank you very much. to the panel. So I want to speak to what all of you have talked about, but then, because it's all buttoned up, there's the integration, there's the monitoring. So there's something that I observe. I know WHO in Uganda helped us try and come up with our WaSH MIS, right? So we want to position water sanitation and hygiene, which actually includes environmental sanitation, because sanitation includes everything. We want to push for its positioning as a key driver of the health outcomes in healthcare settings. But we're still having parallel data sets. So what happens is, like you said, if it's not being monitored, it doesn't exist. So, but we're seeing trends. Like I look at the HMIS, I'm looking at, especially for where I come from, I'm being measured by the number of people that come to seek care, OPD attendance. In other words, I'm being applauded for keeping sick people, not keeping healthy people. What that inherently means that if I have quality of care that you talked about, then I'll have less sick people, so I'll underperform. But if I have, so it's like I said, it's integrated in there. With improved quality of care, the healthcare facilities end up underperforming. When I have poor quality of care, I'll perform because I have high OPD attendances. But if we integrated and we had HMIS that had WaSH indicators in one that are tracked together, that show correlation, like if I had increased ANC attendance or youth seeking health services, increased deliveries, then that should be directly correlated to the level of what quality of care that I have, which is anchored into the WaSH service provision. So if we can, if we can work towards that direction and ensure that everyone is thinking in the same line, to have WaSH as critically monitored in the same HMIS, not parallel systems that we plug into, that would be a win for me.
Great comment, and yes, so important to have WaSH as part of these metrics that we're monitoring, and yeah. So let me pass to the panel. I don't know if Lindsay, you want to start, and then anyone else.
All great points here. You know, Adam, I think the one thing I would love to see, and I agree with what your statement is like, how do we get this at the subnational level, is I wouldn't want to end up making a parallel WaSH like system, right? That they're just looking at their WaSH information and then they have another space where they look at their energy information. Like, that's not efficient. And I'm looking at Mary here. You've run healthcare facilities. Like, nobody wants that. So how do we, you know, are the quality of care people already doing that and we feed into it? And this is going to matter context by context. Countries are different in their processes. Or do we spearhead an initiative but help get others in on it so that we're not just doing WaSH, but we have the energy and the other things to run the healthcare facility? I don't know the answer to this, and again, I think it would really depend talking to our Ministry of Health colleagues, but I think we need to do it in a way that doesn't just like stand WaSH up. I mean, people have had complaints about WaSH Fit being standalone and it being this extra tool that they have to use. And so, you know, how do we integrate, I guess, would be my question on that. Because I think it would help the efficiencies, but only if we don't make it harder for the facilities. I don't know if you guys have other thoughts on the comments.
Okay. No, I agree with what Lindsay said, and I want to use Ghana as an example. So Adam, you said the same thing, and our colleague from Uganda, right? Uganda?
My name is Comfort.
Comfort, yes. So Comfort also said the same thing. I think that when I listen to the three of you, I'm convinced about what I want to say. I've been reflecting on some idea. So when you look at the District Health Information System, the DIMS, in many countries, it's an award-winning data platform, right? And I have been wondering, when you look at the data set, it's mostly public health disease oriented. It is not clinical. There are a few clinical indicators, but it is focused on public health response. So when will we have a clinical health information management system? And it doesn't need to be a different app, but it should be an app that when you open DIMS, you can have two platforms. You click on one, you go to the the public health information management system. And when you click the other, you go to the clinical care information management system. And with time, we may also be able to add administrative systems, because some of the indicators we talk about estate and infrastructure, they are administrative. They are not public health indicators, so they are not in DIMS. They are not in the district health information management system. So when we introduce the clinical component, we'll be able to pull the clinical indicators in DIMS and then bring the other indicators that we want to add. That is when it will now be easy for managers to pay attention to WaSH data, to pay attention to quality of care data, and to pay attention to if my WaSH is improving, is my inpatient attendance decreasing, like Comfort said, which would be a good sign that maybe before the average length of stay on the ward was 10 days. Now it is 5 days. Can we say that the data correlates with WaSH? So we need to really emphasize the clinical health information management system. That is the way we can get WaSH data visible. The second thing is that because also the WaSH data is now in DIMS, which is also a public health platform, you realize that managers don't by default go to WaSH data. And they also find it difficult to analyze the data, because when you go to DIMS, you have to make an effort. And we know the directors are doctors and nurses. They don't have capacity to analyze data. So Adam talked about AI. If we have a way that we can use AI to make the data utilization more easy for them, so that immediately they open clinical health information management system, there's a message popping that this month, hospital number 2 has dropped in proportion of health, district number 2 has dropped in proportion of healthcare services with basic water services, for example. Then the district director can take attention, can take some action, right? But without that, the data is there, they won't see it. They'll wait until WHO says, or even the quarterly performance reviews, they won't include WaSH most of the time unless they have, the data officer is very passionate about WaSH, or the focal points of WaSH is very, is influential and is able to get WaSH into the review meeting. Otherwise, they don't. But if we use AI to make the data easier for them to see, I think it's an opportunity for them to begin to use the data for decision making, because I realize sometimes people run away from doing something, not because they are not interested, but because they don't want to expose the fact that they don't have the capacity, because these are director, right? You're supposed to have the answer to everything. So if your subordinates realize that you can't use the data, it's an embarrassment. So if we make it easier for the director to be able to use the data, I think we get more results, right? So Comfort, I think that will help, isn't it? Yeah. To make the WaSH data more useful, for the decision makers. Okay, thank you.
Okay, well, I think that was really great, and I think the strategy of layering the panel is great, because you're preempting the next speaker and you're building it. And I love your last comment, Mary, about using AI to make some of this data more visible and accessible to people. It's really an interesting thought. But on that note, I'd like to welcome Rick Johnston, who is from the WHO side of the JMP. He's going to talk about evidence and data.
Wow, what a great discussion. Is this on? Okay. So it's good coming last, because you can get some good ideas and reshape what you do. But it's also bad because some of the best points have already been made. So I'm going to end up repeating a bunch of what's been said before. I want to start by thanking Ryan for the nice summary of where we've come over the past, where is Ryan? Over the past 10 plus years. It's been tremendous progress, and everyone should be proud. Let's see. Comfort from Uganda suggested that if it doesn't get monitored, it doesn't get done. And now we are seeing WaSH in healthcare facilities being monitored. That doesn't mean things necessarily get done, but they don't get done if they're not monitored. The visibility is a big benefit, even before actions happen. And I think Ebola was a big eye-opener when healthcare workers were trying to provide services, were trying to provide sanitary settings, and didn't have, running water, didn't have basic hygiene. So that was a real eye-opener, I think. We're just in the process of preparing next year's JMP report. It should come out in, May or something like that. And we have currently, we'll start our country consultation soon, but we've got over 1,000 national data sources now from 170 different countries, up from 154 in our last report. So there's a lot more data. So I want to talk about 3 points then for the future of monitoring and data. And the first is the question of what? So when we define the global indicators of basic WaSH services in healthcare facilities, they were very basic service levels. And there are a lot of really important elements of environmental health services or WaSH or whatever you want to call them that are not in the basic indicators. Things like water quality, actual hand hygiene practice, management or sufficiency of sanitation facilities, functioning of waste management systems. None of that is in the basic indicators. So I think a big next step has to be to reach some kind of consensus around what is a small, manageable but useful set of indicators that go beyond the basic service level. And we're working with UNICEF to make a review of what countries are already doing that go beyond the basic service levels in healthcare facilities as well as schools. And definitely climate resilience will be a part of that, but not the only part. I personally feel like some of the indicators, some of the basic service indicators are formulated around, there's at least one. There's at least one toilet that has menstrual hygiene management facilities. And, that was done to be measurable and comparable and easy, but it's totally not sufficient, especially if you're thinking about a big healthcare facility that's got one toilet that's working. That shouldn't count as, we need to go beyond that. So there's something, I think, around sufficiency. But sufficiency is really hard. How many do you need? Where do they need to be? What level of service do they have to achieve? So getting to sufficiency is hard, but I think we're better prepared to do that than we were 10 years ago when we started this journey. Second point is how to collect these data. And here I'm going to be echoing some of the points that have been made previously. Basically, for both schools and healthcare facilities, we rely on a blend. We're agnostic. We will take data coming from routine administrative MIS systems. We'll take data coming from very detailed facility assessments. If we look at schools, almost all of our data is coming from EMIS systems. If we look at healthcare facilities, it's completely the opposite. Almost 3/4 of our data are facility assessments. Some of them are very intensive, some of them are lighter. Only about 1/6 of our data sources are coming from routine administrative data. Ghana and the DIMS was one of our first that we were able to include in our 2022 report, and it's been an inspiration. And I think that's the direction of travel. We need to see countries building, strengthening systems for routine data collection. We're seeing that in many other countries. India has a tremendous program called Kayakalp that is at scale. Cambodia, Nepal, so many other countries are trying to integrate WaSH indicators into routine MIS systems. We need to strengthen that. But we also need to be realistic and to recognize that routine administrative reporting has its limitations, especially when systems are new. There are big problems with non-response. A lot of facilities just won't enter the data. And they're probably not the same type of facilities than the ones who enter the data. So you get a positive bias for who are early adopters and go to the trouble of filling out the formats. That causes you a strategic problem later on when 2 years later you get higher participation. And guess what? The numbers go down. So nobody wants to report that because it looks like the situation's getting worse, when actually what's happening is that data quality is getting better. There's a whole package of work to be done around ensuring and increasing data quality around MI systems, around routine data collection. But again, that's where we need to go. That's where high-income countries are going. They're not having, harmonized health facility assessments. They have routine data reporting, and all countries need to be moving in that direction. And then the third point is so what? So you've got some data. What do you do with it? The data to action question. And again, here, I think by bringing data collection into routine administrative reporting, routine MIS systems, where it's the health sector itself, the hospital or the healthcare facility administrators who are collecting the data, it's the ministry who's reviewing them, that leads to action much more than an independent one-off health facility assessment that's really expensive and it's only done every 5 years or something. There's still a need for that. You need ground truthing, especially in the early stages of MIS development, and you can get a lot more indicators in, you can get a lot more detailed information from a detailed assessment. Some of that detailed work, I think, needs to migrate into the research area and out of routine MIS systems, global reporting systems, because we're not set up to have that kind of really granular data collection. And that can also inform the what do you do, research around not just what the situation is, but operational research on how hand hygiene can be improved, a million things where I think we need stronger partners with research communities that are separate from the monitoring but are part of that monitoring, evaluation, and learning package. So I think those are my 3 points. Did I cover everything? I think I did. Oh, the last one is that if we do have bigger data through routine admin data, as Adam and Mary made the point, maybe there are some new opportunities with technologies like AI to mine that data and give us suggestions about where actions can be taken and what can be effective. 3 points.
The nice thing is when Rick comes up here, he gives the challenges and also the answers. But I actually wanted to, before sort of summarizing a little, reflecting, I wanted to say one thing about this Ryan Rick piece here. And what it is, I'll explain in a second. But it's we talk about institutionalization of data into HMIS, which is, is incredibly important. But what happened between Ryan and Rick was, and others, I shouldn't just personalize this, but it's fun to do so in a room, is this, this report you did, and you mentioned it, right? 66,000 healthcare facilities, and now the JMP is routinely doing this, and there's more than 1 million healthcare facilities, and it's being reported out every 2 years. And that first report, and people might be like, oh, well, you left out some data, or there's some, whatever, there might be some small issues, but that rang alarm bells for all of us. That's why we're all doing it, and it was incredibly, for me, I think for all of us, just to see the JMP take this up like so seriously and add it to their list of institutions that they monitor has just been really great. So anyway, Rick, that's a big thanks to you, UNICEF, JMP teams. We all use it. But yeah. I think this links, it was interesting when we were talking about financing and even WaSH Fit, we kind of blended monitoring into it, right? And I think we blended back, because you asked a little bit about, or you ended, I should say, with this issue, like what do we use this for, so what on the data? And I think really, if we have this institutionalizing of WaSH indicators into HMIS, we're really going to credibly link to the need part. And then, as Claire was saying, we have the investment readiness, and if there's accountability, if there's monitoring, then that should lead to a really, kind of credible prioritization process that's paired with, this kind of effort on investment readiness. That's, I think, where we need to go. So anyway, I think it's really good. I know, Rick, there's lots of data gaps we need to deal with, and we need to get back that basic water global figure at some point. But anyway, we're on it. You're on it. I've been rambling, so that I'm sure you guys have some questions for Rick and the rest. So I see a lot of hands raised. Okay, good. So we're going to go from right to left. Go ahead.
Thank you, everyone. First question to Rick, since I just heard from you. So basic, what do you mean by basic? To me, if we can connect with the disease, if we can achieve the basic ladder of WaSH or IPC, what should be the disease reduce, improve. If you can connect that, I think that's the basic, number one. And otherwise, it doesn't mean anything for healthcare facility, because in school or in community, basic can be different, but in healthcare facilities, like life and death. That's what I feel. I would like to add one quote of one of the directors that I asked him why you are not sensitized about WaSH. And he replied to me, look, it is, if there is, toilet is not clean, media will not ask me anything about that. If there is any patient is died due to any negligence, then I will lose my chair. So what do you think, what should I do? So that's the straightforward things, and it has been quoted in one of my manuscripts as well, and it is published. So we have to understand the hospital environment. You can see that Mary, we are shooting with questions to Mary, because whenever we talk about healthcare facility inside hospital issue, we are talking about her. We are asking questions to her. But once we are talking about WaSH, we are talking about other people. So we have to ensure what should be the ratio of healthcare professionals when we talk about WaSH in healthcare professionals. Like, I'm not sure what is the statistics of UNC this year, how many healthcare professionals attended to understand WaSH in healthcare facility. If we don't have statistics, I think it's important that from next, we have to actually analyze it. At least 40 to 60, I would say that would be a standard practice when we talk about WaSH in healthcare facility, like not only public health specialist or other things. So, and then, sorry, I'm taking a little bit more for the financing question. So most of the time, I heard from the Director General of Health that they are not able to utilize the grant. WaSH grant, what small amount of grant, but they are not able to utilize the grant because they don't have the capacity, they don't know what to do with the WaSH grant. What happened? They actually change the tiles. They replace the basins. So what is the root cause of this? Because we know that within our recruitment system of the doctors, all the young doctors join sub-district level, and they don't know how to do the budget. So how they will send the budget? It's not about only like lack of budget. In Bangladesh, I never heard lack of budget in healthcare facility. Always I heard that they're not able to spend the budget for WaSH. So that's one of the big, how can we actually train these people? What should be their strategy? I'm not sure. And ethnographic data is not there. What is the root cause? I don't know there is sufficient data. We are just, what we see in our eyes, we are just telling about that. So we think we need more ethnographic data related to this. What are the root causes of WaSH in healthcare facility? Thank you very much.
Okay, I've realized like we have 4 minutes left. Hold on.
Sorry about that.
No, it's good, but I just, before you go, Amy and Christine, are they multi-part questions or are they one question?
I'm going to build on.
Build.
Yes, thank you.
I'm just joking, but let's go through all of you and the panel can take it quickly.
Thanks, Amy.
Yeah.
Yeah, I want to build on what Nuhu said, but I also want to circle back to Rick's point about indicators and getting more specific with indicators. And I think that's great, and I think that's really needed, but I also would love to also move towards implementation guidance. And it can't be top-down like global level guidance, right? It needs to be bottom-up, but it needs to be developed like at the subnational level or the national level, and it needs to have specific recommendations on what to do and how to cost it out. And I think that's just really, really lacking right now. So that's my building on.
I like that. Yeah, you get a little passion in there too at the end of the session. So Christine.
Run faster.
Start with you.
Thanks. So I think this also relates to what Nuhu was saying. From all the times that I've been in the field at healthcare facilities, it really boils down to leadership, I think, whether it's a wealthy facility, whether it's a big one or a poor one or a small one. I mean, Lindsay, Richard, and I, we've all been in the field. You can tell when there's a good leader or when there's a bad leader. And Darcy mentioned it this morning in the management models. How can we build leaders that care about WaSH, as Dr. Mary was saying? There's got to be a way to bring it into curriculum so it's taken seriously, because until we get those leaders involved and being champions for WaSH, and I think, unfortunately, I think it will take physicians talking to physicians to convince them that this is really important. So I see that as a huge need that touches on everything else. Thank you.
Okay, well, thanks, Christine. Okay, we're gonna, that's a lot, okay, yeah, go, Ryan.
Thank you. One quick one. Talking about data, I think we need data that correlates or relates the WaSH IPC interventions in healthcare facilities to health outcomes, especially among children and mothers, for us to be able to show stakeholders that there is evidence that speaks to the impacts of WaSH. And as of now, we don't have a lot of data, for example, on the impact of WaSH on neonatal sepsis, maternal sepsis, and such issues. Thank you.
Okay, thanks. In light of time, I won't summarize. You take what you want from any of those comments, starting with Rick.
Right. So, Nuhu, I think from you talked about a basic, when you meet basic service levels, you should be reducing or eliminating disease.
Yes, I'm sure.
And I want to push back a little bit, because I think for monitoring, you need to simplify and have bright lines, and this is basic and this is not, and things are black and white. And in the real world, it's not that way. And when you get to the basic service level, there will still be healthcare-acquired infections. There will still be inadequacies. And even when you get to the higher levels of service, there will always be disease burdens that can be reduced. Go to Singapore, go to Switzerland, they have healthcare-acquired infections. Basic is better than limited. Limited is better than no service. So it's a progressive realization, I would say. But I think it's a really good point to track the links to health outcomes, your point also. And I think if data are being routinely collected at MISs, those same MISs are also collecting data on healthcare-acquired infections, needle stick injuries, and maybe working with research partners, or that AI, we'll just ask Grok, will see that improvements in WaSH services do lead to reductions in healthcare acquired infections.
Thanks. I will say that beyond just healthcare-acquired infections, I think we also need to be looking at alternative benefits to WaSH in healthcare facilities and demonstrating that, actually, counter to what Comfort said, we've seen, and I always say the same Save the Children example, but like DRC, they did a clean clinic approach, and it actually increased patient uptake because people wanted to come to a clean healthcare facility. So this is not something that you have to be a Richard Magumbe to collect. Like, you go do the health impact research, and HMIS systems, you all can collect proxy indicators in your programs that look at start and finish. What was the revenue at the start, the facility at the start, what's the revenue at the end? We need that data. We need to be able to make that argument to decision makers.
I'm not on the panel, but UNC has done some of this work. I'm presenting on behalf of one of our PhD students in the verbal session immediately following this. So if you want to talk more about this, come join us.
Really? I was going to go the same.
So just to reflect a bit on one of the questions that you raised, which is around the WaSH grant and not knowing what to use it for. And I think that it would be useful, and I was actually thinking about doing this with ChatGPT, just to ask, like, what are all the potential maintenance, operations and maintenance needs in a healthcare facility for the water, the sanitation, the healthcare waste management, all of these things, because we talk about it as like this big bucket, but we're not getting specific about what's needed, what needs to be done. And all of that in-facility O&M definitely can be taken on by the healthcare facility staff and infrastructure. Just like we have a maintenance plan for our homes, and we know every such number of years we're going to look at the roof and we're going to make these routine repairs. We need the same thing. We need this list, and also the cost of what that, and access and sort of indication of you know, what type of specialist or technician would you need to be able to make this repair? Because they don't know how to cost these things. I have no idea. I have to ask ChatGPT, how much does this cost if I'm going to hire somebody to make this repair in my home? So it's the same idea, and we don't, you know, we haven't taken the care to do that, and I think that's a sort of a next development I'd like to see this group take on.
Okay, thank you so much. Nuhu, I just wanted to say that I found the UNICEF approach very helpful when it comes to funds expenditure. So, you know, the FACE form can be technical for the healthcare workers. So usually country office UNICEF will hold a Zoom meeting to teach the focal points how to fill out the FACE form. So that is helpful in how they can liquidate the money and also report back to UNICEF on how the funding was used, right? And I don't see WHO, World Bank doing similar things because they don't have a specialized form. I think UNICEF is the one that has, but I think all the development partners can actually build capacity for the focal points, explaining to them their reporting mechanisms and how they can use funds and report back. Because sometimes the approach for utilizing funds from UNICEF is different from WHO, from USAID, from World Bank. So I think you can help in building capacity. Then the need for data. So one of the things I did in my WaSH in my work in WaSH in healthcare facilities when I was national focal point is that I had a research team. So we didn't get always grants or commissioned research, but we could just go into DIMS and pull the data and do the analysis and write a paper and publish it. So that was data for stakeholders. So whenever they quote us, they would mention Ashinyo et al. You know, so that was also a way of advocacy among the scientific community and the WaSH community in Ghana. So don't wait for funding from donors to do research. If you just do your operational, even if it's just proportions, and you publish it, it's very useful data because we don't have a lot of data on WaSH and in healthcare facilities. And then the final one, I wanted to say, we actually have standards for WaSH in healthcare facilities. So for example, if on a ward I have 50 midwives, how many toilets should I have? How many hand washing stations should I have? It's actually there in WHO UNICEF guidelines. And we have incorporated that into our national guidelines. So please look out for it. It's been there for, I think, many years. Yeah. Okay, thank you.
Thanks so much to our wonderful panel. Let's give them a huge hand. And thanks to all of you for hanging out into the coffee break. 5 AI-generated next steps for all of you. Okay, not AI, Bruce and I. But one is institutionalize WaSH within health systems. 2, prioritize domestic resource mobilization. 3, investment readiness. 4, facility improvement. And 5, integrate data. So that is broadly what we kind of took from this, and we really thank you for all your input.
I'm gonna miss this. You better find a way
Yeah,
to
no,
work
yeah.
together. Imagine, like, we suddenly have different counterparts.
I know.
It's like, what do you mean you're not prepared?
Poor Mary's been